We're thrilled to welcome you to another inspirational and educational episode of Concorde Conversations. Concorde Conversations is an initiative by Concorde Medical Group to educate, empower, and encourage our community about our health so we can all live to our fullest potential. Hi, I'm Dr. Catherine Weinberg, Director of the Adult Congenital Heart Disease Program at Concorde Medical Group, part of Northwell Health. And in today's episode, 2 Hearts, 1 Goal, a maternal-fetal medicine approach to pregnancy, we're going to be talking to our maternal-fetal medicine specialist about preeclampsia. Did you know that preeclampsia occurs in about 1 in 20 pregnancies? And not only does it affect a woman during their pregnancy, but can cause long-term complications. So today we're joined by 2 fabulous maternal-fetal medicine doctors, Dr. Megan Savage and Director of Labor and Delivery at Lenox Hill Hospital, Dr. Shane Wasden. Both are board-certified maternal-fetal medicine doctors at Lenox Hill Hospital, Northwell Health. So many in our community have submitted fascinating questions to ask our experts. And if you have any additional questions, please ask them in the chat box. We only have 30 minutes together, so we're going to go through as many as we can. Remember, we're giving general guidance. So if you have a question about your health, we want to help you. So come in and talk to one of our spectacular Northwell physicians so we can answer your questions and give your health the attention it deserves. Welcome, Dr. Savage. Welcome, Dr. Wasden. We're so excited to have you here today.
Thank you. Thanks for having us.
Yeah, thanks for having us. We're excited.
All right, Dr. Wasden, let's start with you. What is a maternal-fetal medicine doctor?
A maternal-fetal medicine specialist is an obstetrician gynecologist. They've just completed additional training or a fellowship in maternal-fetal medicine, which is really if there's a complication in a pregnancy on either the mom or the baby's side. So really have special training and expertise in dealing with pregnancy complications and managing them. When we were talking about this before, Dr. Savage actually pointed out to me that a big part of what MFMs or maternal fetal medicine specialists do as well is ultrasound. So it's not only pregnancy with complications, but in a way we act as like the radiologists in the pregnancy to make certain that baby's development and anatomy is all progressing as expected.
Great. So Dr. Savage, when should a woman be referred to a maternal-fetal medicine doctor?
Most of our referrals will come through the general OB providers. They'll typically identify a patient that has a pregnancy history or a medical history for really anything. That could be things as common as hypertension or diabetes, or even just general questions with regards to things that happened in a prior pregnancy. And so we're really open to talk to patients about anything that concerns them, anything that we can clarify. Really just be a listening ear for a lot of patients, because we know that, pregnancy is a very stressful time and very anxiety provoking time for most women. And, as a woman myself, you think you get all this education about what pregnancy is and what it's going to be like in that experience. But it's amazing. Even the simple questions, don't be afraid to ask. So we're open to see anybody.
All right, great. Well, today we're going to focus on hypertension and hypertensive disorders of pregnancy. So, Dr. Wasden, let's start with something basic. What is hypertension or high blood pressure during pregnancy?
Typically, high blood pressure or hypertension during pregnancy would be systolic, or that top number on blood pressure, as 140 or higher, and the bottom number, the diastolic blood pressure, 90 or higher. Typically, when we're talking about people with pre-existing high blood pressure, what we sometimes call chronic hypertension, we would want to see that that's present either before the pregnancy or early on, like in the first or second trimester, because as we'll get into, high blood pressure can develop later on in the pregnancy. And if that's something new, then often that's something else, not just, regular high blood pressure.
Got it. So your definition and my definition as a cardiologist differ a little bit, right? Because my definition is 130/80. Anything above that is defined as hypertension. You guys use a different criteria. So it's a little confusing sometimes to patients.
Yeah,
but we work together.
I think it's an excellent point, because there's a lot of physiologic differences in pregnancy. So I think as physicians, even with different specialties, we're trying to tease out, okay, what are these normal changes in pregnancy versus what should we consider a problem or maybe something that needs extra attention. So my sense is things may shift that even in pregnancy, we think about, 130 over 80 as being high blood pressure. But currently, if we're following, professional society guidance about when we think about high blood pressure or hypertension, we would use those cutoffs I'd mentioned. But I think it's a great thing for patients to keep in mind that even 130 over 80 may be something that's good to let your doctor know about in the pregnancy or pre-pregnancy, to have some extra awareness around, because it has been associated with some of the increased risks that we can see for people who, clearly are hypertensive, even using the OB definition.
Right, Dr. Savage, there are different types of hypertension during pregnancy. Can you explain the difference between chronic hypertension and gestational hypertension?
Yeah, absolutely. And I was just going to echo what Shane was saying as well. I think, when people define what an MFM is, I think one of the best parts is that we really do work with a lot of different experts, and it's really a multidisciplinary approach. So we work with Dr. Weinberg a lot, our colleagues in cardiology. And so it's okay to have these different definitions because we're all coming at it from different expertise. So I think makes it really a special relationship. Going back to your question, so chronic hypertension is really pre-existing hypertension that a woman has had throughout her lifetime, or if we diagnose it before the 20th week of pregnancy. Gestational hypertension will be something that we diagnose after 20 weeks in your pregnancy, and it's really more new onset. That's why it's really important for us to take a really thorough history from the patient, because sort of our expectations for a woman's blood pressure and some of the different outcomes and things like timing of delivery can really differ depending upon whether or not a woman has that pre-existing history.
The spectrum of gestational hypertension, what is preeclampsia?
Yeah, and it's a good thing, I think, for us to draw attention to, because it can be quite confusing. There's some different terms out there, like you don't hear as much PIH or what did, remind me, Dr. Savage, what did PIH used to stand for?
Pregnancy-induced hypertension.
Pregnancy-induced hypertension, which really has sort of fallen out of favor, isn't a term that you hear as much, but you may hear pregnancy-induced hypertension, gestational hypertension, preeclampsia. And I would say the two important ones to differentiate between are pre-existing, or what we've been calling chronic hypertension or high blood pressure, and then high blood pressure that develops later on in pregnancy. And you could say gestational hypertension, preeclampsia, they're really all part of the same disease process. Just to be succinct about it, in general, with gestational hypertension, it's just new onset changes in blood pressure, but we're not seeing protein in the urine or other lab abnormalities, versus you may see some of that in preeclampsia. A lot of the risks are similar. So the management of gestational hypertension or preeclampsia is really quite similar.
Dr. Savage, would you like to talk a little bit about how we treat these hypertensive disorders differently during pregnancy? What are blood pressure goals?
Really, with the goal that we're trying to prevent, and why women will get initiated sometimes on medications, that we're trying to keep women out of what we call severe hypertension. So severe hypertension, which can be a hallmark of preeclampsia or worsening pre-existing chronic hypertension, is really when that top number of the systolic blood pressure is over 160, or the bottom number of the diastolic is over 110. If we can keep women sort of out of those severe range blood pressures, it really has been shown that medically indicated deliveries below 35 weeks, development of preeclampsia, and some of the more complications for the maternal and fetal health are significantly reduced. So typically we'll try to keep people's blood pressure below the top number of 140 and the bottom number of 90. But we expect changes throughout the pregnancy too. And so I want patients to know that it's always a little bit of a moving target. Particularly, the physiologic changes that happen with pregnancy in the first and the second trimester. Your body is going through this sort of a little bit of a dilatation. You can think of all of your vasculature just relaxing a little bit. And so in those first and second trimester, we expect your blood pressure to actually be a little bit lower. And then in the third trimester, once that dilatation has sort of really reached its maximum, now your blood volume is doubling. So you have to think of it in the sense that you've got the same heart and the same blood vessels, but now we've got double the volume that your body needs to pump. And so I think thinking of it that way can really help patients understand, why their blood pressure is changing and why we have different goals at sort of different times of pregnancy.
So it's not unusual during your pregnancy that your dose of medication changes, correct?
Correct.
Correct. And I would just add to that, especially for pre-existing high blood pressure, we may want to try and keep it in the more normal range and make some adjustments as the pregnancy progresses just because of some of the expected changes we may see. Versus with preeclampsia or new onset high blood pressure, really we're going to try and prevent those numbers from getting too high. And I think it's still a little bit of an outstanding question academically of, all right, what's the best blood pressure range or goal for those patients who've developed new onset high blood pressure in the pregnancy? Certainly keeping them out of the severe range, but should we keep it more normal or let it run a little more high? And we'll work closely with our cardiology colleagues and patients to talk about, where we want that to be.
All right. So does delivery cure preeclampsia?
Delivery, I'll tell patients, is the cure for preeclampsia. But one important thing for patients to keep in mind is even though delivery is the cure for it, can take days, weeks, or even longer for some of those effects of preeclampsia to go away.
Can you develop post-partum preeclampsia? So preeclampsia after you deliver?
Yes, absolutely. And this is definitely something that I speak to a lot of my patients that have either developed gestational hypertension or have pre-existing chronic hypertension. I find that, women are so selfless and, willing to do anything, when they have that newborn. And so I find that when women are admitted in the postpartum period, they always sort of know, they'll always say to me when they get readmitted postpartum that they knew something was off that week leading up, right? But they're, attributing it to that maybe they didn't get a lot of sleep or they're trying to breastfeed or, welcoming a lot of visitors to introduce their, new baby to the family. And so I think during that time, when some women will have those features and some of the symptoms that are associated with preeclampsia, sometimes it just kind of gets explained away. And so I always tell my patients to be very mindful during that time period that although it's a very busy and exciting time period, to not forget about yourself and make sure that you're taking care of yourself and keeping a close eye on your blood pressure as well and acknowledging those symptoms. And if you're feeling things, to really advocate and reach out to your provider.
Yes. And so it's so important that you follow up after you deliver as well. Okay, Dr. Wasden, what are the signs and symptoms of preeclampsia? And what are red flags? When should a woman seek attention?
Interestingly, and I'll explain to patients, a lot of times there's not any outward signs of preeclampsia. There can be, and we'll certainly go over the red flags or things that people should keep an eye out for, but it's quite common that people may be feeling well, and the first sign of preeclampsia is just that we're seeing a new onset elevation in their blood pressure or protein in the urine. Sometimes the signs or symptoms can be a little more subtle, like just not feeling well or even nausea or vomiting. So always follow up, like Dr. Savage was suggesting. If you're not sure, you're feeling off, always great to reach out to your provider. The more sort of red flag symptoms are things that I would certainly say call your doctor or come to the hospital for, which are less common but good to be aware of, is if you had a persistent or a severe headache. If it's the type of thing you rest or you take Tylenol and it goes away or feels like a typical headache, that would be less worrisome, but certainly something that's sticking around or feeling unusual. Changes in the vision, like black spots in the center, are really just not the same vision that you typically have, or a persistent or severe pain in the upper middle abdomen or on the upper right side.
And if your blood pressure is ever 160 over 110, come into the hospital, right?
Correct. Yeah. And I guess sometimes it's hard to know if patients have some way to assess their blood pressure at home or not. But certainly if you are able to assess your blood pressure at home, if you're seeing suddenly new elevations in your blood pressure, even if they're not in that severe range we mentioned, that's good to let your doctor know about or provider. Or certainly, if it's getting in that severe range, top number 160 or higher. The bottom number, 110 or higher.
Dr. Savage, how is preeclampsia diagnosed?
So preeclampsia is typically going to be diagnosed. It can, like Dr. Wasden was saying, it's sort of like chicken or the egg, which comes first, right? So some patients, the first thing can be their hypertension, which is very obvious, right? Because you're sometimes coming for your routine prenatal visits, you're here for an ultrasound, we take your blood pressure. So if we have suspicion that based on your increasing blood pressure or symptoms that you're having, and you meet the criteria for the blood pressure, then we'll typically check your urine to see if you're having protein in your urine. And that's really sort of how we differentiate between, that gestational hypertension, which is typically not associated with protein in the urine, versus preeclampsia if it is. And once we have a suspicion for preeclampsia, we're also going to do some lab work to check on your kidney function, your liver function, your platelet levels, which are sort of the clotting factors in your blood. Because if any of you have any lab abnormalities, that can help us get a sense of just whether or not you're having preeclampsia or if you're having preeclampsia with more severe features. And the management will be a little bit different based on those results.
What are risk factors for preeclampsia, Dr. Savage?
So I think it's important to say that although there are a lot of underlying risk factors, anyone can get preeclampsia, right? So about 2 to 8% of all pregnancies globally will be affected by preeclampsia. So I want all patients to be vigilant. But I would say the most common risk factors, there's a lot of racial ethnic disparities. So women of color are typically at increased risk compared to non-women of color. People with pre-existing chronic hypertension, diabetes, and obesity are probably the most common, or a pre-existing history of preeclampsia or hypertension in a prior pregnancy.
Someone developed preeclampsia in their first pregnancy. What's the risk of recurrence?
It will depend a little bit on the severity of preeclampsia, like how early they developed it, how early they needed to deliver because of the preeclampsia. But I would say anywhere in that 10 to 20% range, just roughly speaking.
What about the risk to the fetus with preeclampsia? We're talking about the risk to the mom, but what about the fetus? Dr. Savage.
Or Dr. Wasden. We're both ready to go.
We can talk about preeclampsia all day.
All day.
There you go.
So anyone that has any hypertension in pregnancy, we're going to be monitoring during what we call the antepartum period or during your pregnancy for growth, right? Because we have to think that at the end of the day, the placenta is just like an organ, just like everything else. And so sometimes if we have hypertension, I'd like to think of it as sort of a low-level chronic stress on that placenta. And so sometimes we can see that the baby might be starting to grow a little bit smaller than we would anticipate. And so, if that happens, we continue to monitor you a little bit closer. But as to what Dr. Wasden was saying, it really is the timing of the delivery that I think is most consequential for the baby, because as we advance in gestational age, the complications of prematurity are going to be significantly reduced. And so really the most important outcomes with regards to the fetus or the baby is at what weeks you were diagnosed with preeclampsia and at what gestational age you were delivered.
What about aspirin? Why do we use aspirin, and what about the dosage?
There's been a lot of things studied to see if they have potential to help reduce the risk of preeclampsia. So I would say in every pregnancy, really, there should be some risk assessment based on, your personal risk factors or other methods to determine if you're at higher risk of preeclampsia. And aspirin's been, one of the few agents that's been shown to be helpful to reduce the risk of preeclampsia for people that we know are at increased risk of it. It is important, though, that aspirin is started early in the pregnancy. And it's a little, not so straightforward when you first think about it, because preeclampsia, often, again, no signs of it in the early pregnancy. But it really is starting to develop. It's just not something we're seeing outward signs of, and then often develops later in the third trimester. But by starting the aspirin, it seems in the pretty much end of the first trimester, between 12 to 16 weeks, and ideally before you pass 16 weeks, that seems to help reduce the risk of preeclampsia. It's important to take it every day. They found if people weren't taking it more than 90% of the time, you didn't see the benefits of helping to reduce the risk. And then, like you already mentioned, that the exact dose that we should be using remains a little bit of an academic question. We would say everybody should take low-dose aspirin if you're at increased risk, but that could really be anywhere from 81 milligrams a day, which is the low dose we use in the United States, up to, I would say, 162 milligrams a day, or two of those baby aspirin a day.
Besides aspirin, what kind of lifestyle changes can a woman make to prevent preeclampsia or hypertension during her pregnancy? Dr. Savage?
Dr. Wasden and I speak about this a lot. We're huge advocates for women really optimizing their health and whatever that means for them. So, whether or not, whatever you define as sort of being active, getting exercise, I think a lot of women are told during their pregnancy that they should maybe not exercise and do certain things. And I always laugh to myself whenever I even go to an exercise class and the instructor at the front says, is anybody injured and is anybody pregnant? I've never been in a class where a woman has answered yes to the pregnancy, but I'm always so curious about what the guidance would be from the instructor at the front. Because really everything with moderation, right? Women are smart. So I tell my patients, if you're exercising and it's feeling good, then trust yourself and continue to do it. If you feel like it's too much, well, then dial it back. And as the pregnancy progresses, those are going to be different. But really, when you think of it, sort of just the physical strength and the conditioning, and really your mental health and wellness, and being as active as you can, even if it's taking a walk. We're not expecting anyone to, train for a marathon during their pregnancy day one, but just to really sort of maintain that physical strength and clarity, I think is huge for patients.
Dr. Wasden, do you have anything to add to that?
I would add, I think Dr. Savage really touched on the most important thing, which I think is your overall well-being and physical health, and just that exercising pre-pregnancy and in pregnancy, that's been well studied and really helps to optimize or improve the health of the pregnancy. Mm-hmm. I would also add, if you have pre-existing medical conditions, let's say diabetes or pre-existing high blood pressure or hypertension or lupus or other medical problems, in general, the more those conditions are optimized and really well taken care of before pregnancy, the healthier your pregnancy is going to be. So I would say, if you're not certain, reach out to a maternal fetal medicine specialist. We'd be happy to see you, or your obstetrician, your midwife, just to make certain that those things are as well, taken care of before you pursue pregnancy.
Yeah. So pretty much you and I have the same kind of preventive advice for people, right? Don't smoke, don't drink excessively, eat your vegetables, right? Exercise and get enough sleep. And if you do those things, you tend to do better during your pregnancy as well.
Absolutely.
See, that's why we're friends. All right. Dr. Wasden, are there long-term complications from preeclampsia? And who should be screened?
And I almost think it's funny. This is a better question to turn in your direction, but I'll answer it from the obstetrician standpoint. That for us, with risks of preeclampsia to the mother or to the baby, a lot of that's mostly around the time of in the pregnancy or delivery. And as long as you have a diagnosis and we're aware of it, I'm confident you can be safely managed and taken care of. Immediately after pregnancy, it's really about blood pressure control, that we want to make sure you're not getting into those severe ranges of blood pressure. But in general, people will start moving in the right direction. Their blood pressures will improve. They'll start feeling better. But there's more and more research showing that there's a link with preeclampsia and long-term cardiovascular health or cardiovascular disease. And probably part of what we're talking about, reducing risk of preeclampsia by optimizing your health, or even outside of pregnancy, doing the things you had suggested is going to optimize your cardiovascular health. Same thing, that if you've had preeclampsia in the past, it's almost like a signal to us that we know you're at increased risk of heart disease. And not to be worried about it per se, but hopefully be empowered by it to follow up with your obstetrician, let your primary care doctor know you had preeclampsia. And I think great to have follow up with a cardiologist as well, so that you're making certain that you're doing the things that we already mentioned, plus checking lipids and everything else to reduce your risk of having heart disease, so you can be there with your children and family.
Exactly. That's our goal, to get people out until they're grandmas or great grandmas, right?
Yes.
So, all right, last question. If you had one action step to recommend to our viewers and start today, what would it be? Dr. Wasden, would you like to start?
Yeah, and I think it goes back to what we've already touched on. That I think there's just a huge body of research that really supports the benefit of being active and physical exercise, and even being out in nature. So sometimes when we're talking with patients and we're trying to institute these difficult lifestyle changes like that, it's hard for people to change, the way they're eating, or there may be certain things in their life that exercising regularly or getting to the gym in some way is really difficult. And I would just keep in mind that it doesn't have to be this formal going to the gym type exercise. Find something that you're moving in your body, that you enjoy doing, that feels good, whether that's walks, yoga, going for a run, hiking, maybe going to the gym and weightlifting. But I think there's lots of options that you can pursue. And I would say to try and make that become a regular part of your life, I think will make you feel better in the immediate period. And long term, I would say what is one of the best things you could do for your health.
Okay, Dr. Savage, what's your advice?
I would say 100% agree with Dr. Wasden. But I also want to mention too, just really valuing and protecting sort of your mental health. I find that a lot of patients, if they need to come see a maternal-fetal medicine doctor or a cardiologist in their pregnancy, that sort of that label of being a high-risk pregnancy is extremely anxiety-provoking for patients. And so just really knowing that, just because you have to see us doesn't mean that you're going to have a bad outcome or an adverse outcome in your pregnancy. A lot of what we do is sort of preventative and preparation. And so just to really be mindful of that and empower yourself with really good knowledge, right? Think of where you're getting the sources of the information. There's a lot on social media. There's a lot in sort of the lay press. And while I really, really love that women educate themselves in those ways, I just really want to, empower them to find sources that are really accurate and, based in research and a solid foundation, because I just find with so many of my patients, there's a lot of anxiety and most of it is coming from a lot of misinformation or misunderstanding. So just to really protect your mental health in that way.
That's great advice. So thank you, everyone, for tuning in to another inspirational and educational episode of Concorde Conversations. We want to thank Dr. Savage and Dr. Wasden for their expertise to educate, encourage, and empower our community. And as part of our Concorde community, we hope you'll share in our mission and pass along our emails and webinar links to your friends and family. In addition, please like and subscribe to our YouTube channel. We know you may have additional questions about your health, so come in and speak to our fabulous maternal-fetal medicine doctors. We care about your health. We care about you. Thank you so much for joining us today.
Thank you.